and release a specific hormone. These hormones, they do control and regulate the activity of target cells and organs. Hormones influence growth, development, digestion, and regulate metabolism and reproduction. Glands release the hormones into the blood to a stimulus, another hormone, or to achieve a threshold. These are some of the hormones released by these glands. I'm sure we are going to look at in more details so that you are able to get it. But this is just but a few. So glands stop releasing hormones when they receive a signal to turn off the hormone production. And this is normally achieved through a process that we call direct feedback. So the endocrine system maintains homeostasis. Feedback tells a gland to increase or decrease a hormone production so that the body can return to a homeostasis. When the concentration of a hormone reaches a threshold, hormone production is normally turned off. Just for your information, especially for all of us who love history, saying that the first hormone to be discovered was secretin hormone, and that was in 1901. This is how the feedback works, and we have two major types of feedback. We have the positive feedback and the negative feedback. You can agree with me that positive feedback is best illustrated during childbirth, whereas negative feedback has several instances where we are able to demonstrate, not forgetting the temperature regulation. On my left, we can start by looking at the positive feedback during childbirth. So we say that during labor and delivery, we have normally oxytocin, which stimulates contraction. Oxytocin is released, and this one stimulates uterine contraction, which pushes the baby towards the cervix. Now guys, so when the baby's head is or the baby is pushed towards the cervix, the head of the baby pushes against the cervix. And when this happens, nerve impulses from the cervix are transmitted to the brain of the pregnant mother. So the brain stimulates pituitary gland to secrete oxytocin. Is oxytocin that is normally carried in blood to the uterus, and when that happens, it further stimulates the uterus, and more contractions are given birth, and the more contraction they push the baby towards the cervix. So this one is a positive feedback, guys. An increase in oxytocin leads to a further increase in oxytocin, and that makes it a positive feedback. Looking on my right, we have the body temperature that exceeds 37 degrees Celsius. Here, the nerve cells in the skin and brain are stimulated. So, temperature regulation center in the brain is also stimulated. So when this stimulation occurs, sweat glands throughout the body are stimulated and they open, and thus an organism is able to lose more temperature, and thus the temperature is down regulated. In negative feedback, guys, an increase of substance A leads to a decrease in substance B, and vice versa. And that's how different it is from the positive feedback. There are three major types of hormones. We have the peptide hormones, also known as the protein hormones. We have the steroid hormones and the amine hormones. Further explanation to them, but you can be able to look at it. So peptide proteins, Steroids, amino acid derivative. If you try to distinguish between the three different types of hormones, we can distinguish it in terms of synthesis, storage, solubility, receptors, effects, and examples. In this case, when looking at the peptide, you're saying that they are synthesized as prohormones, requiring further processing, e.g. cleavage to activate. But in storage, it's stored in vesicles, that's the regulatory secretions. We're saying that most are polar and water soluble and can travel freely in blood. They bind receptors on the cell membrane and transduce signal via the use of second messenger systems. Often fast onset transient changes in protein activity, though gene expression changes can occur. Examples will include insulin, glucagon, prolactin, ACTH, adrenocorticotropic hormone, gastrin, and parathyroid hormone. Those are examples of peptide hormones. This is commonly compared to the steroid hormones that are synthesized in a series of reactions from cholesterol, released immediately, as you call it, constitutive secretion, generally nonpolar, and require carriers to travel in blood. So we say they normally act through second messenger. They bind to intracellular receptors to change gene expression directly. Alteration in gene expression slows onset but lower duration than peptides. Examples include corticosteroids, cortisols, aldosterone, estrogen, progesterone, and testosterone. On the amino acid derivative, these ones are mainly synthesized from amino acid tyrosine. They are stored before release. Some are polar, like adrenaline, others must be protein bound. Adrenaline acts on the membrane receptors, while thyroid hormones act directly on nuclear receptors. Adrenaline functions like peptides, okay? Thyroid hormone functions in a similar manner to steroids. So you find that thyroid acts through a second messenger. Examples of amino acid derivatives include adrenaline, thyroxine, triiodothyronine. And those are the different examples of hormones. So in short, we have peptide hormones, steroid hormones, amino acid derivative. You should be in a position to distinguish the three groups. Great. Which question should the nurse ask when assessing a client for an endocrine dysfunction? Have you noticed any pain in your legs when walking? Have you had an unexplained weight loss? Have you noticed any change in your bowel movements? Have you experienced any joint pain or discomfort? Very good. Have you noticed any pain in your legs? It is exactly as you have placed it. That this probably is a musculoskeletal disorder. Have you experienced any joint pain or discomfort? Musculoskeletal disorder. Have you noticed any change in your bowel movement? Probably GIT. So most of the questions we are going to discuss and see why B is not only true, but exactly true, and that's why we pick it. So we'll be looking at it in the due course. But as for now, that is what we need to have as our correct answer. Hormones produced by the hypothalamus. Of course, we say that the hypothalamus is the control center. So the control center, we can say that we can be able to count uh, thyrotropin releasing hormone, TRH, the one that normally stimulates the release of thyrotropin or thyroid stimulating hormone, dopamine, the one that normally inhibits release of prolactin. We have gonadotropin releasing hormone, GnRH, stimulates the release of FSH and LH. We have somatostatin. Somatostatin inhibits the release of TSH and growth hormone. We have corticotropin releasing hormone, CRH, and you're saying that CRH stimulates the synthesis of POMC, that is the pro-opiomelanocortin, and release of beta lipotropin and ACTH. Those are the different hormones released by the control center that normally target cells in the anterior pituitary gland. Looking at the second gland, we have the thyroid gland, and on my file left, you can be able to see and identify where the thyroid gland is. It is surrounded, we have the right lobe and left lobe, we have the isthmus, and we have the trachea. You can be able to extend your neck so that we are able to locate these parts. On my far right, we can see the type of different hormones that are normally released by the thyroid gland, starting with calcitonin, the one that is involved in downregulation of serum calcium, followed by T4 and T3. T4 is thyroxine and T3 is triiodothyronine. These ones are normally secreted as a result of the function of TSH on the thyroid gland, the thyroid stimulating hormone. And remember, we have just seen from the feedback that TSH is produced once TRH has been produced by the control center. So the control center releases TRH. TRH stimulates the pituitary gland to release TSH. And which part of the gland? Anterior pituitary gland, that is adenohypophysis. Great, guys. Great. T4, T3 are commonly referred to as the metabolic hormones. Comparison of T3, T4. We compare in terms of potency, rate of secretion, onset of action, half-life, storage, and inactivation. You find that in terms of potency, T3, that is triiodothyronine, is 4 times more potent than T4. We say 4 times T4. Yeah. Rate of secretion, you find that it's less secreted compared to T4 that has 10 folds more secreted compared to T3. In terms of onset of action, see that T3 is rapid in onset, whereas T4 is low in onset. The half-life of T3 is around 3 days, whereas the half-life for the T4 is averagely 7 days. In terms of storage, you're saying that storage, we have T3, there is less storage, whereas T4, there is more storage. Inactivation, it's rapidly inactivated, that is T3, and it's slowly inactivated, that is T4. So you can see the one that is more metabolically active is rapidly inactivated, and it should not be forgotten. Great, guys. So what's the function of the thyroid gland? Any guess? Correct. Function of the thyroid gland is to release thyroxine, which controls metabolic rate, and calcitonin, the one that lowers blood calcium levels. Very good, guys. That was done perfectly. Types of thyroid diseases. We have hyperthyroidism, an overactive thyroid, hypothyroidism with PO. This is an underactive thyroid. We have goiter. This is improper growth of the thyroid gland. We have thyroiditis, inflammation of the thyroid gland, thyroid nodules, formation of lumps in the thyroid. We have thyroid cancer, cancer cells in the thyroid tissue. Ladies and gentlemen, these are just but a few. We have more types of the thyroid diseases, and some of them you're going to encounter in the due course of this unit. Okay. So hyperthyroidism, you can see it now. I want you to look at my beautiful, I don't know if it's a girl, a man, but you're saying that excessive production of the thyroid hormones, that is the T3, T4, leads to someone experiencing a condition known as hyperthyroidism that is generally characterized by irritability, nervousness, heat intolerance, sleeplessness, vision problem. Okay, so this guy has hair loss, bulging eyes, a large thyroid gland, abnormal heart rate, increased appetite, irregular menses. We have hand tremors, vomiting and diarrhea, enlarged liver, frequent sweating, and finally hair loss. Characteristics of hyperthyroidism: excessive production of the metabolic hormones. Okay, guys, so this is a question for you. I want to give you 1 minute to attempt. Which nursing diagnosis takes highest priority for a client with hyperthyroidism? Guys, hyperthyroidism, we've said these are excessive T3, T4. The GIT is going to be super active. Yes. So the A, we have risk for imbalanced nutrition more than body requirements related to thyroid hormone excess. We're saying if the thyroid hormone excess is excess, then more food components are going to be broken down. Okay? So we're going to have less because of that excessive expedited process of metabolism. Risk for skin integrity related to edema, skin fragility, and poor wound healing. Poor impaired skin integrity. Disturbed body image related to weight gain and edema. Of course, this one we are going to eliminate immediately because of the weight gain. Now, hyperthyroidism, the GI is going to be super active, and the body might not be having sufficient time to retain or have more weight. So patients with hyperthyroidism are likely to present with weight loss. Okay, weight loss. Okay. And that's why the correct answer is D. Imbalanced nutrition less than body requirements related to thyroid hormone excess. In clients with hyperthyroidism, we say excessive thyroid production leads to hypermetabolism and increased nutrient metabolism. This condition may result in a negative nitrogen balance, increased protein synthesis and breakdown, decreased glucose tolerance, and fat mobilization and depletion. These changes put the client at risk for marked nutrient and calorie deficiency, making imbalanced nutrition less than body requirements related to thyroid hormone excess the most important nursing diagnosis. Risk for impaired skin integrity related to edema, skin fragility, and poor wound healing, and disturbed body image related to weight gain and edema may be appropriate for a client with hypothyroidism, which normally slows the process of metabolic rate. And talking of hypothyroidism, look at where we are now. Signs of hypothyroidism. Starting with the general, there's fatigue, feeling cold, there's weight gain with poor appetite, weight hair loss, lungs may have shortness of breath, pleural effusion, skin, patients may suffer from paresthesia, myxedema, intestines, we have constipation, ascites, reproductive system, we have menorrhagia, extremities, they may be called with carpal tunnel syndrome, muscular, we have delayed reflex relaxation. Heart rate, you find they have slow pulse rate, and pericardial effusion. The pharynx, you may find some hoarseness, poor hearing, psychological poor memory, and concentration. Guys, you can be sure of this one. Patients with hyperthyroidism and hypothyroidism do share some characteristics, and one of it is hair loss. Trying to compare the two, hypothyroidism and hyperthyroidism. In hypothyroidism, we have lethargy, fatigue, weakness, muscle aches, paresthesia, forgetfulness, cold intolerance, weight gain, dry skin, body hair loss, constipation, bradycardia, cardiac enlargement that could result in heart failure, have generalized edema and puffiness, the one that we commonly refer to as myxedema, menstrual problems, we talked of menorrhagia, goiter, which may or may not be present. In terms of symptoms, when you look at hyperthyroidism, where we have excess production of T3, T4, we normally have personality changes, where someone is irritable, has agitation, and mood swings. Patients could present with nervousness and fine tremors. We have diaphoresis, that's excessive sweating, heat intolerance, weight loss, smooth, soft skin and hair, diarrhea, palpitations, cardiac dysfunction, tachycardia, atrial fibrillation, protruding eyeballs, the ones that we normally refer as exophthalmia, hypertension, enlarged thyroid glands, goiter. Ladies and gentlemen, you can see goiter can result either from hypothyroidism or hyperthyroidism, together with also the hair loss that we have already mentioned in this place. In terms of Nursing interventions. What are you supposed to do as a nurse? For hypothyroidism, you're supposed to monitor vital signs. You're supposed to administer the main drug, that is levothyroxine sodium. You're supposed to advocate, since this guy have weight gain as a result of decreased production of T3, T4. You advocate for low calorie, low cholesterol, low saturated fat diet, and discuss a daily exercise program such as walking so that you can work on the weight. Remember, these patients have weight gain. You also need to assess the client for constipation, provide roughage and fluids to prevent the constipation. You provide a warm environment. Remember, they are cold intolerance. Provide a warm environment. Avoid sensitive and opioid analgesics because of increased sensitivity to this medication. It may precipitate myxedema coma. You monitor for overdose of thyroid medication. And when you have an overdose of thyroid medications, clients will present as if they are suffering from hyperthyroidism. And this is characterized by tachycardia, chest pain, restlessness, nervousness, and insomnia. Lastly, for patients with hypothyroidism, you instruct the client to report episodes of chest pain and other signs of overdose immediately. What of the hyperthyroidism? In this case, you need to provide adequate rest. Remember, the patient is very irritable, is agitated with mood swings. Provide adequate rest. Provide a cool and quiet environment. Remember, they are heat intolerant. You obtain daily weight. Remember, in this case, they are going to lose weight. Obtain daily weight. Provide a high calorie diet. This is the opposite when you're dealing with hypothyroidism. In this case, they are likely to going to lose weight. Provide a high calorie diet. Avoid administration of stimulants. In hypothyroidism, we are saying that you avoid sedatives and opioid analgesics because of increased sensitivity to this medication. Number 6, you're supposed to administer propylthiouracil, PTU, methimazole to block synthesis of thyroid hormones. Administration of these drugs, propylthiouracil, methimazole, carbimazole, to block synthesis of the thyroid hormones. Remember, if your client is pregnant or expecting to get pregnant, whatever, the drug of choice in such a category is normally propylthiouracil. Number 7, administer iodine preparation that inhibit the release of thyroid hormone. Administer iodine preparation that inhibit the release of thyroid hormones. Number next is that since the patients are normally agitated, irritable, mood swings, nervousness, and so on, we normally try to treat these kind of symptoms that we normally group together as sympathetic response. And one of the drugs that we use the beta blockers. And we use the non-selective beta blocker. And this is propranolol. Remember, this drug has to be used in caution, especially in patients with COPD, whereby it might worsen the COPD condition, or in diabetes mellitus, whereby it may mask the symptoms of hypoglycemia. Next, you have radioactive iodine therapy to destroy thyroid cells. We also have subtotal thyroidectomy, where part of the thyroid is removed. And when you're doing that, you have to monitor the patients for hypothyroidism symptoms. Lastly, you elevate head of the bed for the clients experiencing exothermus. You give them low salt diet, artificial tears, use dark glasses. You tape eyelids at night if possible, so as to make them comfortable. And that's all about hyperthyroidism and hypothyroidism differences, and in terms of management, which drug is important and which one is further used. At this juncture, I'll want you to explain to me why a patient with hyperthyroidism, that is those patients with elevated T3, T4, are normally given medications such as propranolol. Thank you for that answer. For those who have not sent, you can just chat and send, and we'll be able to review the answers. So here is a question for you. We are asking, which instruction should be included in the discharge teaching for a client after thyroidectomy for Graves' disease? Thyroidectomy, we are removing the thyroid gland, and when you remove it, the patient is likely to suffer from hypothyroidism. So which instruction should be included for a patient with suspected thyroidism? That is what we're trying to say. In exercise to improve cardiovascular fitness, have regular follow-up, use nasal desmopressin acetate, keep accurate record of input and output. Accurate output, whatever. That is for renal problems. A patient has a problem with the thyroid gland. Same to D, cardiovascular problems. So if we are good students, then we should be focusing on B and C. But you find that the correct answer is C, because the patient the nurse should be taking good care of this patient and monitoring the follow-up just to rule out the development of hypothyroidism. Nurses should instruct client with Graves' disease to have follow-up care, because most cases of Graves' disease eventually result in hypothyroidism. Annual thyroid stimulating hormone tests and client's ability to recognize signs and symptoms of thyroid dysfunction will help detect thyroid abnormalities early. Recording input and output is important for clients with fluid and electrolyte imbalance, but not thyroid disorders. The DDVP is used to treat diabetes insipidus, and in this case we are talking of hyperthyroidism, which is not indicated. Although exercise is important to improve cardiovascular fitness, the importance of regular follow-up is more critical for this particular patient. Which finding will the nurse expect to assess in a patient with Hashimoto's thyroiditis? Ladies and gentlemen, it is important for us to realize that Hashimoto's thyroiditis is one of the hypothyroidism condition. And in hypothyroidism, we say we are going to have weight gain and not weight loss. For that reason, A and B automatically becomes wrong, and we end up concentrating on C and D, because hypothyroidism normally results in increased weight gain, constipation, being cold intolerance, and so on. And this weight gain is normally associated with decreased appetite. And that's why constipation comes in, and C makes us have the correct answer. It's important to know that Hashimoto's thyroiditis is an autoimmune disorder, and it's the most common cause of hypothyroidism. It is seen most frequently in women older than age 40. Signs and symptoms include weight gain, decreased appetite, constipation, lethargy, dry, cool skin, brittle hairs, coarse hair, muscle cramps, weakness, sleep apnea. Okay, find that weight loss, increased appetite, and hyperdefecation are characteristics of hyperthyroidism. Weight loss, increased urination, increased thirsty are classic signs of uncontrolled diabetes mellitus. Weight gain, increased urination, and purplish like red stripe are characteristics of hypercortisolism. Okay, thank you guys. Thank you very much. We can attempt this one, and this one is just but a complication of hypothyroidism because it is hypothyroidism that the patients are called intolerant. So he's saying that during surgery, a patient develops hypothermia. The circulating nurse should monitor the gland closely for which finding rebound, hypothermia, metabolic acidosis, anaphylaxis, respiratory alkalosis. Thank you. Someone has already ruled out C, anaphylaxis. Great, great. Same to A, yes. So when you look at now B and D, metabolic acidosis and respiratory alkalosis, you know that when you have hypothermia, it means what? It means less food components are going to be broken down. And if that happens, then it means the body is going to engage alternative sources of energy. And when alternative sources of energy are produced or are found and acted upon, it will be the same like in diabetes type F mainly, whereby alternative sources of energy are now broken down the proteins, resulting in metabolic acidosis. And that's why B becomes the answer. So when the patient's temperature falls, glucose metabolism is reduced. As a result, metabolic acidosis may develop. You find that rebound hypothermia, anaphylaxis, and alkalosis are not associated with hypothermia during surgery. Okay, may I just get comments on what we have done so far? Great, I'm happy that you are there with me. So we have now the master gland. It's called the pituitary gland. It has two major parts. You have the anterior, which is normally referred to as adenohypophysis, and the posterior referred to as the neurohypophysis. The pituitary gland normally settles in a bone, and we normally call it the sella tussica. Sella tussica is so significant when you're looking at the pituitary gland. So you have a small assignment for you here. I'm saying, can you list 8 hormones produced by the neurohypophysis? Neurohypophysis. Okay, so just a typo there that you really need to get the neurohypophysis. Just get there. Yeah, I'm already there. Produced by the hypophysis. Let me correct it. Great. Hypophysis. Hypophysis, yes. List 8 hormones produced by the hypophysis. So the pituitary gland is also referred to as the hypophysis. So these are the pituitary hormones and their functions. We have the anterior lobe, adenohypophysis, and posterior lobe, the neurohypophysis. So the anterior lobe, we have growth hormone, adrenocorticotropic hormone, luteinizing hormone, endorphin, we have enkephalins, prolactin, follicle stimulating hormone, and lastly thyroid stimulating hormone. For the posterior pituitary gland, we have the vasopressin and oxytocin. Very good. Yes, thank you. Thank you so much. So looking at the pituitary gland, you're saying that we have various conditions associated with the pituitary gland. So underproduction of hormones from the pituitary gland results into a process or a condition known as hypopituitarism. So on assessment, we have mild to moderate obesity, we have reduced cardiac output. Patients with hypopituitarism normally presents with infertility, sexual dysfunction, fatigue, and low BP. Tumors of the pituitary gland may also cause headache and visual defects. Pituitary is normally near the optic nerve, and that's why patients with a tumor on the pituitary glands will present with visual defects. Client may need hormonal replacement for specific deficient hormones. Remember, we have said that for the pituitary gland, at least we have 8 hormones produced by the anterior and 2 stored by the posterior. So we need to provide emotional support to the client and the family. We need to encourage the client and family to express feelings related to disturbed body image or sexual dysfunction. Lastly, we need to provide client education. What about hyperpituitarism? Hyperpituitarism, excessive hormones, is characterized by large hands and feet, thickening and protrusion of the jaw, arthritic changes and joint pain, visual disturbances, diaphoresis, oily, rough skin, organomegaly, hypertension, atherosclerosis, cardiomegaly, heart failure, dysphagia, deepening of the voice, thickening of the tongue, narrowing of the airway, and sleep apnea. These are some of the classic signs of hyperpituitarism. Hypoglycemia interventions. You need to provide pharmacological intervention to suppress growth hormone or block the action of growth hormone. Prepare the gland for radiation of the pituitary gland or for stereostatic radiosurgery if prescribed. The nurse needs to prepare the gland for hypophyseectomy if planned. The nurse needs to provide pharmacological and non-pharmacological intervention for pain. The nurse needs to provide emotional support to the family and client and encourage client and family to express feelings related to disturbed body image. Guys, we can attempt this. Okay, I'm giving you 1 minute. A client is recovering from transphenoidal hypophyseectomy. What should the nurse instruct the client to do to ensure oral hygiene? Removing of the pituitary gland. Remember, we are targeting the seller to see carbon. Yeah, it's just on the nasal roof. Yeah. So what should we do to a client to ensure oral hygiene? Rinse the water with saline, perform frequent toothbrushing, clean the teeth with an electric toothbrush, floss the teeth thoroughly. So after transphenoidal surgery, the client must be careful not to disturb the suture line while healing occurs. Frequent oral care should be provided with rinses of saline, and the teeth may be gently cleaned with oral swabs. Frequent or vigorous toothbrushing or flossing is contraindicated because it might disturb the or cause tension on the suture line. And that's why option A was correct. Great, guys. You're wonderful people. So hyperphasectomy is the removal of the pituitary gland via craniotomy or sublabial transphenoidal, that is endoscopic transnasal approach. Complication of craniotomy includes increased ICP, intracranial pressure, bleeding, meningitis, hypopituitarism. Complication of sublabial transphenoidal surgery include CSF leakage, cerebrospinal fluid leakage, infection, diabetes insipidus, and hypopituitarism. Their post-op care will include monitoring vital signs, nausea, vomiting, level of consciousness, elevate the head of the bed, and monitor for increased ICP. The nurse needs to instruct the client to avoid sneezing, coughing, and blowing the nose because this but only increases the intracranial pressure. Yeah. You need to monitor for bleeding, monitor for and report signs of temporal diabetes insipidus, monitor intake and output, and report excessive urinary output. If the entire pituitary gland is removed, clients will require lifelong replacement of ADH, antidiuretic hormone, cortisol, and thyroid hormone. Monitor for and report signs of infections and meningitis. Administer antibiotics, analgesics, and pyretics as prescribed. The nurse needs to administer oral mouth rinses as prescribed. Client may be instructed to avoid using a toothbrush or toothbrush gently with an ultra soft toothbrush for 10 days to 2 weeks after surgery. Instruct the client in the administration of the prescribed medication. So when you look at the pituitary gland, it leads us to discuss two of the most common conditions associated with the pituitary glands. So we have the diabetes insipidus and syndrome of inappropriate antidiuretic hormone, CADH. Whereas diabetes insipidus is characterized by hyposecretion of ADH, CADH is characterized by hypersecretion of antidiuretic hormone. The common causes of diabetes insipidus include trauma, stroke, surgery, and other as idiopathic causes. Similarly, syndrome of inappropriate ADH is normally caused or results from trauma, stroke, stress, malignancies, especially those ones of the lungs and the pancreas, are likely to result in excessive ADH production. So, furthermore, ADH is characterized by dehydration and polydipsia, polyuria, postural hypotension, tachycardia that normally leads to vascular collapse if not rehydrated. Syndrome of inappropriate ADH normally leads to oliguria, concentrated urine, hypertension, tachycardia. So patients with diabetes insipidus have inability to concentrate urine. So they have a low urine specific gravity. Remember the normal is between 1.010 to 1.025. In the case of CADH, that is syndrome of inappropriate antidiuretic hormone, patients do suffer from hyponatremia, and which normally leads to changes in mental status and level of consciousness. So generally, patients with diabetes insipidus will present with fatigue, muscle pain, and weakness. This is compared to CADH, where patients present with anorexia, nausea, and vomiting. In terms of the nursing interventions that we partake for each of the two patients, in diabetes insipidus, the one that's characterized by hyposecretions of ADH, we do monitor vital signs, nausea, vomiting, cardiovascular status. We ensure that the patients are in a safe environment because of the postural hypertension. We employ the fall precautions. We monitor electrolytes. We look at adequate fluids. Monitor inputs, outputs, weight, serum osmolarity. We avoid diuresis inducing foods. For CADH, we also monitor the vital signs and cardiovascular status. We ensure safety for a patient because in this case we have changes in level of consciousness. We monitor fluids and electrolyte balance. We monitor for signs of increased ICP. We implement seizure precautions and monitor input and output. For diabetes insipidus, we also use vasopressin. Since the ADH is inadequate, we use vasopressin or ADH, yes, especially when ADH is severe, the deficiency is severe. So desmopressin acetate, it could be subcutaneous, IV, intranasal, oral, when we have water intoxication. These patients are always advised, so the healthcare provider should make sure that they wear a medical alert bracelet. For CADH, syndrome of inappropriate ADH production, you elevate the head of the bed to a maximum of 10 degrees to promote venous return and serum osmolarity. You restrict fluid intake as prescribed. Administer IV fluids, especially normal saline or hypertonic. You use loop diuretics to facilitate diuresis, only if serum sodium is at least 125. You give potassium replacement. Vasopressin antagonist is normally given to decrease renal response to ADH. So a client with syndrome of inappropriate ADH is experiencing lethargy, weakness, headache, and muscle ache. Which intervention is the nursing priority? Lethargy, weakness, headache, muscle ache. Administering diclomycin, antibiotic, is that necessary? Monitoring serum osmolarity, that necessary? Obtaining dietary sodium intake? Because of the nature and the way they present, yes, with altered level of consciousness, the patient is supposed to be put on seizure precaution activities, okay? That's why B is correct. A nurse is caring for a client with diabetes insipidus. The nurse should anticipate administering. Patients with diabetes insipidus have produced less or no ADH vasopressin. So as a nurse, you should need to anticipate administering the same, and that's why D is correct. Differences between diabetes insipidus and CADH. In diabetes insipidus, we have high urinary output because we don't have ADH to control diuresis. Low levels of ADH, hyponatremia, dehydrated, and lose too much fluid. But for CADH, syndrome of inappropriate ADH production, we have low urinary output, high levels of ADH, hyponatremia, overhydrated, and retain too much fluid. Remember, both will present with excessive thirst. Ladies and gentlemen, it's good to have at least 5 differences between diabetes insipidus and syndrome of inappropriate ADH production. These are further explanation of what you need to expect of the two diseases. One is soaked inside, that is inside has more fluids. Another one inside has less fluids, okay? The one with less fluids is also experiencing hypernatremia as opposed to the one with more fluids, the one that will be suffering from hyponatremia. So that's why we say you engage or you start those seizure precaution measures. Which sign and symptom should the nurse expect in a client diagnosed with syndrome of inappropriate ADH? Syndrome of inappropriate ADH. Excessive thirst, orthopnea, ascites, concentrated urine. Glands the nurse expects. They are soaked inside. soaked inside, saying that excessive thirst is a sign of diabetes insipidus, is a deficiency of ADH. Orthopnea is difficult breathing when in supine, which is not a sign of CDH. Ascites is excessive accumulation in the peritoneal cavity, which is not a sign of ADH also. So excessive ADH causes CDH, which causes increased water retention, leading to increased fluid and scan. So concentrated urine is of concentrated urine because much of it is being held. Much of it is being held. D becomes the correct answer because much of the fluid is being held and not released. So that guy is going to be releasing concentrated urine. Okay. Client is diagnosed with syndrome of inappropriate. The nurse informs the client that the physician will order diuretic therapy, restrict fluid intake, and provide sodium replacement to treat the disorder. If the client does not comply with the recommended treatment, which complication may arise? Complication of syndrome of inappropriate excessive ADH. Retaining more and more fluid and more. When you retain more and more, we are going to have cerebral edema. Non-compliance with syndrome of inappropriate ADH may lead to water intoxication from fluid retention caused by excessive ADH. This in turn limits water excretion and increases risk for cerebral edema. Hypovolemic shock results from deficient fluid volume. In contrast, CADH causes excessive fluid volume. The major electrolyte disturbance in CADH is dilutional hyponatremia and not hyperkalemia. Because CADH doesn't alter renal function, potassium excretion remains normal. Therefore, severe hyperkalemia doesn't occur. Tetany results from hypocalcemia and electrolyte disturbance not associated with CADH. Which endocrine disorder should the nurse assess for in a client who has a closed head injury with increased ICP? Increased ICP. Increased ICP. Diabetes insipidus. Very good. This is a tumor. Tumor of the adrenal medulla. Diabetes insipidus can be caused by a brain tumor or infections, pituitary surgery, cerebral vascular accident, renal and organ failure, or it may be a complication of head injury with increased intracranial pressure. Diabetes insipidus is a rare antidiuretic hormone insufficiency. Hashimoto's causes hypothyroidism. Gynecomastia is an enlargement of the main breast. Okay, great. From this juncture, okay guys, congratulations and thank you so much. I think you can just like and press and subscribe. When we meet next, we'll be looking at adrenal glands. Thank you so much.